everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loupes that are built for you. Q Optics is more than magnification. Custom crafted through the lens loupes engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive TrueFit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized stress-free fit and all-day comfort. The Ergo Direct Vision loupes with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loupes for a straight-ahead gaze and complete ergonomic relief. And with crisp edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loupes and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Hi, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm really pleased to have as our guest Dr. Philip Haigh. Dr. Haigh is an endocrine surgeon and surgical oncologist at Kaiser Permanente, Los Angeles Medical Center. He is a regional resource within the integrated health system for patients with complicated thyroid and parathyroid disease and sarcoma. He also does research on population studies relating to primary hyperparathyroidism and thyroid disease. In addition to all of this, he serves as the chair of the Surgical Services Subcommittee at the Kaiser Permanente LA Medical Center for quality improvement of their surgical subspecialties. Hi, Phil, and welcome to the podcast.
Geeta, great to be here.
Great to have you. All right. So, Phil, could you tell our listeners a little bit about yourself, including where you grew up, your training background, and how you arrived at your role at the Kaiser Permanente?
Yeah, I guess I'll start with medical school. I'm born and raised in Calgary, and I went to medical school at University of Calgary. And then after that, I did a rotating internship in North Vancouver, probably one of the last years to have a rotating internship.
Mhm.
And then I went back to Calgary for 5 years to do general surgery residency. And then after that, I did a surgical oncology fellowship at John Wayne Cancer Institute in Santa Monica. Donald Morton was my supervisor, and also Armando Giuliano.
Mhm.
Then I engineered a third year of breast and endocrine surgery with Armando Giuliano. I also worked with Orlo Clark for a month during that year, so that was fantastic. And then I took my first job at University of Toronto. I was there for 2 years, and that's where I met you when you were a senior resident with me on my service. So that was brings it all full circle today.
It does.
And then after Toronto, I actually met my future wife in Santa Monica. So anyway, I took a job at Kaiser Permanente and have been there ever since. And then and slowly over time, morphed into the quality position. Surgical Services Committee is really a quality committee that looks at performance improvement on for various outcomes. We have NISQIP, so we use that as a PI tool, and then there's peer review and whatnot in that committee as well. So I've been doing that for probably 12, 14 years or something like that.
So a long time. Okay. Well, thanks for sharing that. And for our listeners, I mean, you just heard that Phil and I have known each other since I was a senior resident and Phil was a brand new attending, primarily, I think, focused on breast endocrine and then general surgery call. We have our adventure stories from there, which I can get into another time. That's where we met. And then we have other things in common. For example, when Phil was a new attending there, I was actually planning to go to San Francisco to work with Orlo Clark for a year for my endocrine surgery fellowship. And so we have Dr. Clark as a mentor in common. And then, of course, we've stayed in touch over the years because of our shared interests in endocrine surgery and being a part of the American Association of Endocrine Surgeons. Now, what our listeners may not know, Phil, is that you were also part of the core surgical ergonomics interest group, which then ultimately became the Society of Surgical Ergonomics. And I have to tell our listeners, because, credit where credit is due, we would actually never have become a society if it wasn't for Phil's tireless efforts in figuring out which forms needed to be filled and then spending hours on end filling them out. And I think, Phil was the inaugural treasurer. I was the inaugural president. Sue Hallbeck was the president-elect, and Tara Cohen was our secretary. And so I think we had a text chain going at some point about figuring out what the name of the society will be. Was it going to be Society of Surgical Ergonomics? Was it going to be Surgical Ergonomics Society, etc.? And then we, I think, decided that the acronym SES was a Korean girl group band, and so we weren't going to go after that. So fun times, and it continues. Phil, with all of this, could you share with our listeners what led to your interest in surgical ergonomics and why you joined the group and why were you sort of working to help us get into the form of a society and continue the work that we started?
Yeah, so it started with a single event for me,
Hmm.
like it's about 14 years now, so maybe 11 years out of fellowship. I was doing a thyroidectomy and I completed one side, and then I went to I operate from the opposite side of the table when I do thyroid surgery, and I went to the other side of the table, and I realized after the fact that I didn't tilt the table back towards where I now was standing, so it was tilted away from me. Had my headlight. I was doing it. I remember the resident I was working with, the senior resident, vividly,
Hmm.
and suddenly just absolute out of the blue. It was like a knife, it's like a Bowie knife in the back of my neck around C3 level.
Wow.
Just tremendous sudden pain, acute pain. And so that was sort of the event that started it all. And so the acute pain, developed into chronic pain. So over weeks and months and 6 months, 12 months, I still had neck pain and I still do. So, but it did start from that one work-related event. And I mean, I've had several MRIs of my neck. The discs are fine, the bones are fine. It's some sort of soft tissue problem and muscle or ligamentous, pain. Tried absolutely everything you can think of, including acupuncture. So anyway, chronic neck pain, work-related neck pain. And what was so striking is that I just didn't tell anyone. It took ages for me to feel I could whisper to someone. And I actually, at an AAS meeting, I took aside a past president and I whispered to her, hey, do you have neck pain from doing thyroid and parathyroid surgery? And then, yes, yes, all the time, I'm looking for ways to, mitigate it. And then someone else, and they said, oh, ask the other past president over in the other part of the room, ask that person about his disc replacement and all this. So it became apparent to me that this is a problem. And so I lived with this neck pain, and you had your interest group. So I mean, when you had developed that interest group on Twitter, I just thought this is exactly what I'm looking for. So when I joined, I mean, my interest actually exploded when I joined, and really it was talking to you, but also the human factors folks that I never normally would ever interact with. So Dr. Susan Hallbeck and Dr. Tara Cohen. So talking to those human factors experts I mean, it just opened up this huge vista for me on surgical ergonomics, and that's how it sort of amplified. So then, parenthetically, when you and I, meet at AAES, and we always talk about these black and white photographs of the first AAES meeting, I thought we've got to, like, there's this interest group, there seems to be a movement afoot, let's lock it down. And so I paid $30 to the Attorney General's Office of California. You fill out a form. It took about all of 10 minutes after we locked in the name. So
Yes, that took longer than 10 minutes locking in the name.
yeah, but that text string was beautiful with the Korean band. But yeah, we didn't want to be the SES. So submitting that $30, the 10 minutes of work in a form, and kind of that what started it. But then there was a whole bunch of work needed after that. But that was, I mean, it has been quite the ride, and now finally, we're starting to spread the word, and it's quite an exciting time.
Great. Thank you for sharing that journey. I was smiling because it took me back to those memories of 2020, 2021. We officially became a society in June of 2021. So it's actually been 4 years. And I have to tell our listeners that Phil is the next president-elect. Now, let's unpack some of the stuff that you mentioned, Phil. So, as I was listening, I'm reminded of kind of other conversations that we've had with others over the years, but also a recurrent theme on the podcast. Okay. So, the first thing was I couldn't say anything. I wasn't sure whether to whisper it to somebody. I'm glad you did. And I actually remember having this conversation with you. We were sharing a cab heading to one of the AES meetings from the airport to the hotel. And I was telling you about my jaw pain and how I think it was coming from my neck. And I think that's the first time you told me about what happened with you with that one particular case. And it still kind of goes to show with doesn't matter which specialty you're in, what level you're in, there's this stigma attached to our symptoms and, being human. And so at least us sharing our stories helps at least to some extent to destigmatize kind of, us developing work-related musculoskeletal injuries. The second thing that you mentioned, in speaking with the two previous past presidents and then finding out a lot of people have had surgery. So we studied this. I think I had a resident at the time in otolaryngology, and we actually surveyed members of the AAES as well as the endocrine section of the American Association of Head and Neck Surgeons. And I mean, if you look at this group, then the rate of musculoskeletal symptoms is above 90%. Okay. And they've all done all the things we talk about, taking NSAIDs, treating ourselves, massage therapy, physical therapy, chiropractors, and, don't chide yourself for going out there, as you say, evidence-based. I consider myself evidence-based. I had an NIH-funded lab, okay? And here I was trying acupuncture, I was trying chiropractor, I was trying, I think at one point I did craniosacral therapy. I don't even know what these things, were at the time, but I think what I realized is what you're describing. Now, I have degenerative changes in the spine and I have a bulging disc. You don't have any radiologic abnormalities, and this is what we've talked about if I want to refer someone to the massage therapy episode of the podcast. What we get is this myofascial pain, right? From repetitive injury. Like you said, it's muscle, it's ligaments, it's fascia. But the thing is, it's real, right? It's real. And conventional therapies don't really, address it. You brought up some of the things that you did to address it, and then there are a whole bunch of other things that have then become kind of ergonomic best practices, which we can get into. Now, you've got this pain, and now it's unrelenting because every time you do a thyroidectomy, you're reminded, oh my gosh, every time you add a neck dissection, you're reminded. So I know you did something different. You thought outside the box and brought back the use of microscopes for thyroidectomy. So tell me how this happened for you. How did you end up thinking about it? And then what did you find? Because I know you studied this too and published about it.
Yeah, I mean it's a fun story. So I was talking to a colorectal surgeon colleague of mine who'd left our institution and moved to the Middle East, and he's, how are you, Phil? I said, oh, everything's great. I love my job, but I have, chronic neck pain. And he said, well, have you tried the operating microscope like neurosurgeons use? And I mean, here's the colorectal surgeon is telling me this. I'm like, no, I haven't thought of that. So he says you should. So I actually went home after meeting with him. We went hiking up to the Hollywood sign. Anyway, I got home and Googled, operating microscope for thyroidectomy. And I mean, there was maybe two articles 10 years prior, and I couldn't find anything more recent. And they used it for, enhancing the nerve identification rate and whatnot. So I thought, oh, well, and one sentence in their paper was, it has potential ergonomic benefits. So I thought, huh. The next day at work, I went to call the neurosurgeon, the chief of neurosurgery, and asked him about could I try the operating microscope, and like, absolutely, Phil, go ahead, let's do it. I'll come and help you on your first case. So no kidding, like 4 days later, I plugged the machine in the hallway and played with the instruments, and it's quite I mean, it doesn't take that long to learn, but it's an $850,000 machine. There's maybe four, I think we have five in the hospital, so
Mhm.
they're available. He was willing to let me use it. So about 5 days after that, I tried it for my first thyroid, and I mean, it was unbelievable. So you stand up absolutely straight. Actually, the first part of the operation, you expose the thyroid, and then once the lobe is partially exposed, then I bring in the operating microscope and stand up perfectly straight. The neck pain pretty much is much abated. You get to stand up straight. It's that bubonic plague of the forward head posture in open
Posture.
surgery is just absolutely killer.
That's the
So
root cause of our misery. Root
sustained
cause.
forward head posture. So you don't have that. And then there's all these side benefits, awesome lighting, that the light on the operating microscope doesn't get impeded by someone's head. And the
And it's
zoom,
not on your head, right?
you're right. Yeah, so there's no weight on your head or anything. The zoom is tremendous. I mean, once I had this tiny bleeder on the nerve, and usually we just put Surgicel, and this was a little pesky thing, and so I got a microvascular forceps and just tangentially applied a clip under about 20 times zoom, and I mean, it was phenomenal. So I use it for all thyroids. I've been doing that now for, I think it's 2.5 years now. There's always one available for me. So I do have a department of neurosurgery, and plastics uses them. I mean, they've been very,
Mhm.
very forgiving, allowing me to use them as part of the team. And so, I mean, yeah, it was outside the box. I don't think I could do thyroid surgery anymore really without it. I still haven't used it for parathyroid surgery. I get that question by residents all the
Yeah.
time. Like, and every parathyroid looks abnormal under that thing. I mean, they all seem huge. So I just haven't quite figured out normal and abnormal,
Hmm.
and
Hmm.
a minimally invasive parathyroidectomy takes a very short time. So I still haven't, used it for that or anything else, but I still do open surgery for, large sarcomas, and they take a long time. And one of the worst operations actually for forward head posture, it's just an incredible angle, is an axillary dissection teaching a resident. So when you're above the arm teaching an axillary dissection, it's nuts.
Yep.
The forward head posture. So
Yep.
yeah, so thinking outside the box, that my operating microscope was revolutionary. I have one other little tidbit of out of the box. I'm working on designing sort of the glasses. I'm nearsighted, so I wear glasses. But when you stand up, you can actually get a little more head extension if you have huge angle of the lenses. So we're going to 3D print these hinges, and then I'm going to cut the arms of my glasses, and I'm working with like not a he's a cartoonist, but he uses software to 3D software and
I see.
called CAD. I don't know what this program is, but anyway, he developed this picture of a hinge. I'm going to 3D print it. I'm going to try it on my glasses. But that all started because I contacted an optometrist in New Jersey, I think it was, and we talked through it. Like, is there something? I wanted to get prisms put on my glasses. Like,
Mm-hmm.
could I just stand up straight and put blocks of prisms on my glasses? But that didn't work out so much. But we can change like a severe angle of your lenses like this. So I'm going to try that. And
Yeah, I have a question about that actually. So I meant to ask you this. Did you use loops before you started using the microscopes? Have you ever used loops for thyroidectomies? No.
yes, no, I'm one of the few that never use loops.
Okay. That's okay because, a lot of people, I think it's 50-50. 50% of people use them, 50% don't. So the reason I asked is because what you're describing is essentially what the loops now have become, right? So the standard loops used to be you have your glasses and you have the magnifying part fixed into the lens. They're called through the lens loops, right? And those angles of declination, what angle that magnifying part sits in your glasses made a difference because if your angle wasn't steep, you were having to bend your neck further forward, right? Exaggerated forward flexion, which then worsens the pain. So over the years, I saw that people were trying sort of steeper and steeper angles of declination. And of course, in the last few years, we've all seen kind of with the addition of prisms and everything, now you have these deflection loops where it's just like looking through a microscope. So the reason I also bring that up is, when you described using the microscope, I'd seen the same paper. And after you did it, I actually went to our neurosurgeons and mentioned this, and they were willing to help me use it. But as it happened, it was never available when I was booking my cases on particular days. And so it fell by the wayside. But then when I got the deflection loops, I found it was doing the same thing as a microscope, keeping my, head straight. So for our listeners, what Phil is describing, I know he said out of the box thinking, and I guess another way to look at it is necessity is the mother of invention, right? You've got to do something. But this is a well recognized ergonomic intervention, right? Changing the way that we work is a well known ergonomic intervention. And, some of the other things you will read about on the Society of Surgical Ergonomics website or that we've talked about on this podcast is incorporating breaks and stretches into your workday and workflow, wearing, using anti-fatigue mats, all of these other things. So, Phil, could you tell our listeners if you've incorporated or how you've incorporated some of the other ergonomics recommendations? I mean, obviously, the microscope is a huge one for you for at least thyroid surgery, but what are some of the other things that you do and how you work?
Yeah, I mean, so you mentioned micro breaks. So, well, we had like a physician wellness session at our medical center, and I was invited to kind of do the physical, pain, ergonomic side of things. And
Mm-hmm.
we sort of made a push for these micro breaks. I showed them Susan Halbeck's data. I mean, look, micro breaks are so easy to do. I'm a huge fan, and there's some pushback from some folks like, oh, I don't want to slow the case down, and there's a good analogy to micro breaks. So Susan Hallbeck found that there really wasn't a lengthening of the procedure, and so the idea is if you take a break for a minute or minute and a half, you actually feel better and more with it and alert and no less pain, and
More
so
efficient. Yeah.
you'll get on it, so you're more efficient. And I mean, there is the analogy I use is that, there's a marathon runner in the 70s, Jeff Galloway, and you run, walk, run, it was called. So you'd run at least, and then I ran two marathons in my life, and it was with the LA
Wow.
Lakers in Santa Monica, and they ascribe to this philosophy of run, walk, run. So you run a mile and walk a minute.
Mm.
So and it doesn't slow you down. It in fact improves your performance, at least for a new, amateur marathon runner. So it doesn't slow you down, it actually makes you faster. So the same is true, I believe, for surgery, and you can do them at any time. People are worried, well, you don't want to do it when there's bleeding. Well, no, you don't, but I mean, there's so many times in a case you could actually do them. And I posted the other day on X, there, during that Kamchatka earthquake, that these Russian
Yes, I
surgeons
saw
that
your
got
post.
down there
Yeah.
that kind of stopped working. They were taking a forced microwave, and who knows what they were doing. Were they in the middle of a distal anastomosis on a cabbage? I don't know. Were they in the base of the brain and doing some 8-hour neurosurgical case? Who knows? But you can do those. You can do these micro breaks anytime. So I introduced the micro breaks to the institution, and just normalize them. So anesthesia knows about them, nursing knows about them. I do them on every case, and it's almost imperceptible actually when you some cases you do it, it can be imperceptible, like waiting for the
Path.
we
Yeah. Frozen
we wait a
section.
long time in our intra PTHs. We have the long we don't have the intra assay, so 30-minute waits. Well, you're standing up straight and gabbing and doing some stretching, and that's
Yeah.
basically when you do it, it's imperceptible, and it can be imperceptible most of the time. So that's a common thing. Now I wouldn't say that everyone does them.
Yeah. I was going to ask you if your nurses do them
Yeah, they do
postpartum.
them when we all do them, resident team, anesthesia. They participate. Um, yeah, so the anti-fatigue mat was a no-brainer as well. I just had the operating room buy two mats per room. That's about $100 each, so that's $200 per room. Very easy to do. So yeah, all this is
We did the same. Yeah. Low hanging fruit.
low
Yeah.
hanging fruit. So those have been very helpful.
This is all, good to hear. I have kind of a related question, and I think I remember this from one of our previous conversations. And someone has asked me this, I think, after Grand Rounds presentation and things. So if you have an all day long case, right? Can you double team it? Can you have like two attendings on the case just so that we avoid that cognitive and physical fatigue? Like maybe you're doing a long sarcoma case, or maybe I'm doing something like total thyroid central neck, lateral neck dissection, which is kind of that long day for me. Have you tried that? I haven't tried it, so I couldn't answer the person asking me the question, but I think I recall you've tried it.
So soft tissue sarcomas of the retroperitoneum are a common operation I do. And they tend to be larger. Often they can be all day. So for those, I used to it was me and the resident and the intern.
Mhm.
And then at some point, maybe 10 years into my career, and it was actually before I had neck pain, I just thought this is so ridiculous, get help. So, oh, and I used to, go along the arteries and veins myself, dissect along them, and you realize 10 years into your practice that the vascular surgeons do that every day. They're way better at it than me. And so get them to do that part and they do a better job. So I get all sorts of folks involved, appropriately. But
Mhm.
I have a colleague now and we will be together or not. So we'll be together for a while and holding this basketball-sized tumor, or
Mhm.
someone steps away and has some food and a glass of juice or something. I mean,
Right.
no case for those bigger tumors do I do by myself with a resident anymore. So always have a partner. It's just better, probably better for the patient. And I always just, I'm so puzzled by these articles that came. There was an article, a couple articles about a year and a half, 2 years ago, and can you do two Whipples in a day safely? And
Right.
the answer was yes. And I just thought, why would anyone ever want to do that? So, I think we just need a bigger, I personally believe we need a bigger workforce in surgery. And
Yeah.
I'm kind of getting a little off tangent, but I think I would never, want to do two Whipples in a day. I don't think it should be done. In fact, I'd want a resection team and an anastomosing team, preferentially, something like that. Split it up,
Mhm.
tag team. I
Work
do think,
smarter. Work
yeah.
smarter.
So,
Yeah.
yeah. So those are my thoughts on that. I'll just add that analogy, which I'm thinking the analogy is not great, but I've been exploring the idea of a pitch count in surgery. So
Mm-hmm.
in youth baseball and in fact Major League Baseball, pitchers will almost never pitch more than 100 pitches in a game, and the idea is that they're going to cause like an elbow, ulnar collateral ligament strain or tear, and so.
Repetitive strain injury, right?
Yeah, but it's explosive, it's violent, and in surgery, it's not like
Mhm.
that. It's more like cycling, but holding a fixed posture for a long time. But I've been exploring that, this when you exceed 100 pitches, you're at risk of injury, and so they don't do it. So I do believe there is a pitch count in surgery, like a number of cases per day or per week, where if we exceed it, I think we're in a high risk zone for MSK injury. It's just really hard to prove, but I'm on to the very introductory steps of that goal.
Got it. Okay. Well, I've heard you talk about the pitch count, so thank you for mentioning it here as well. So, Phil, I have this kind of broad question for you now because, as we said, we're 4 years that the society has been in existence. And, early on, we decided that this interest group where we were sharing how we became interested in surgical ergonomics was not going to be just us kind of sitting around and complaining. We were going to do something about it. And that's kind of what led to the next steps. And of course, our mutual mentor, Dr. Clark, had a lot to do with this because I remember, anytime I would say, well, we don't have this at our institution or something, he would always say, well, if you don't have it, then figure out how to get it, right? And so that's what we were doing when we were thinking about Dr. Clark and kind of thinking of forming a society. So let me ask you, as the president-elect of the SSE, what do you think would be our next steps? I know we've made a lot of strides in improving awareness of ergonomics. Obviously, if you look at the last 2, 3 years of various society meetings, there has been some talk or some panel, where ergonomics has been a point of discussion. So we've helped improve awareness and awareness of using best practices to reduce the risk of injury. But there remain two huge contributors, which I call elephants in the room, right? So there's still much work to be done in sort of getting our organizations, meaning our institutions, invested in this aspect of wellness. And then there's the second piece, which is the industry and instrumentation contributing factors relating to our injuries. So, realizing that this is a very broad question and no one's going to hold you to any promises, but what do you see as kind of next steps?
Well, I think it's going to be multi-pronged. We are spreading the word, but I mean, look, in other areas of our society, the word is spread for decades, and so we've only been doing this for 4 years, so it's actually still in its in very infancy. Our
Mhm.
circles, our immediate circles, it seems like people are getting it, but I don't believe it's not really in the fabric the penetration hasn't been that much, I believe. So spreading the word, I think, is going to go on for decades, actually. So I think it's still important to do that, think of different ways to do that.
Hence the podcast. That was my number one reason,
Yeah, so and couple with, really try and collaborate with societies. Hopefully, bigger societies are open to it, and as a liaison, I mean, all sorts of liaisons are, go to the ACS, for example, at whatever society it is, and I mean, it'd be wonderful to have a liaison of the SSC at ACS. So that would help with getting into the fabric and
Yeah.
more hardwired. The instrument size again, so that's I hear over and over that that's the problem, and I think we have to take baby steps. Maybe I think something has to be presented to the FDA. In this time, it might be a little bit tricky, but
Right.
just to get sizes of instruments labeled on the device, like so. Again, an analogy would be just something so simple as PPE gowns. They have to be labeled how the size of the gown. They have to be a surgical gown. An NBA basketball has to be labeled. And in fact, the women's NBA basketball is a smaller size basketball
I
than the
did not know that. Okay.
yeah. So if we want some instrument handles that are smaller for the small-handed surgeons who tend to be females, at least label what's glove size is this stapler. And if it says size 8 on it, then at least we know that, okay, well, that's the size 8 and there's going to be issues. So I think that's the babyest step. But I think the whole, if there's a 7-step process, that has to be sort of the first step.
Yeah.
And I'm willing to take that on, but as the president of the SSE, figuring that out. But it seems to be roadblocks wherever you go. And then what you've developed at the SSE with industry relations, we have to obviously foster that, because then it'll be impossible if they're not involved too. So, but yeah, the instrument size is being too big and not made for small-handed surgeons. It's just astounding to me that we're still, it's still an issue.
Yeah. I agree. And I think we've made sort of some strides. Obviously, the American College of Surgeons has its ergonomics task force and its recommendations. And as you said, cross-pollination with SSE, would be even better. And then we have sort of some involvement of industry, and we've had these webinars through the Society of Surgical Ergonomics addressing some of these issues with instrumentation. I think we had a whole one on stapler design in December of 2024. And then I'll also refer our listeners back to episode 1 with Dr. Susan Hallbeck of the Surgical Ergonomics podcast, where she talked about the hand size study that we've been doing, right, as part of the society. Providing kind of this cross section of the current surgical workforce so that it can maybe inform better instrument design. I asked Sue a simple question. I said, why can't everything come in 2 or 3 sizes, just like the gowns, like you mentioned, right? Small, medium, large. And unfortunately, it's a little bit harder than just saying small, medium, large. But then this is why we need the data. This is why we need the work. This is why we need people thinking about this. All the young people looking to sort of start their surgical careers, if they're looking for an area of academic interest, you can reach out to Phil, you can reach out to other members of the society and, see if we can push the needle and get things better for all of us.
Totally agree.
All right. Phil, I am very appreciative of your time. By the way, for our listeners, Phil is actually on vacation, and because I had to reschedule the podcast recording once, he was kind enough to meet me while on vacation to get this recording done. And so I was going to say I'm always grateful, but I'm doubly grateful. So thank you.
Pleasure, Geeta. Thanks very much for inviting me.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. enter your name for the Ergo Angle Deflection Loops and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loops giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loops. Thank you.